Well, thank you all for being here, and thank you to the wonderful guests today who are coming to speak about the effect of technology in healthcare, in our healthcare systems, and in all of our institutions. Our approach to this is really to look at not just the way the world has changed over the last 2 years, but if anything, what we've learned over the transition that COVID has taken us through is that the systems that we have in our hospital systems, in our healthcare systems, amongst all of our physicians, these tools, these systems are not only critical to keep us alive, but they're critical in the way that they keep learning and changing and moving. And so we are really excited today to hear from different voices who meet physicians and hospital caregivers and the systems themselves across different geographies and across different timelines in order to help us understand what and how innovation is taking a new role in a post-pandemic, I don't know if we can call it post-pandemic, but in a continuously changing reality for our healthcare systems. We've brought together, as I said, different voices. We are still waiting to hear, and we're hoping that that Professor Gamzu will be able to join us today. We are in touch, and I will keep you all updated on that. But glad to get us started actually today with each of the panelists who will give their perspective, first of all, on who they are and what role they play in the hospital system or in the healthcare system. And then I have a whole bunch of questions to help us start this conversation about the use of innovative technologies in healthcare systems, the way that's changing as we've seen in a post-pandemic period, and then what that actually means for the continuous learning and adaptation of technology and innovation in those systems moving forward. So I'm thrilled to invite our first speaker, Ruth Gotian, to introduce herself and tell us a little bit about what it means to be the Chief Learning Officer at Weill Cornell Medical in New York. So Ruth, thank you for being here, and tell us a little bit about yourself and what it is that you do and your role in the hospital.
Hi, everyone. My name is Dr. Ruth Gotian, coming to you from New York City today, where it is hot and humid. My career started in a very unusual way. I think almost everyone can say that. My bachelor's and master's degree are in business, and like all good business students, I went to work in finance and international banking. I was actually working in Israel for a couple of years, came back, led what's called an MD PhD program, where my students got the dual MD and PhD simultaneously. It was a program that had a 3.5% acceptance rate, and I did everything cradle to grave: recruitment, admissions, operations, budgets, grants, alumni affairs, event planning, you name it, I did it. And at the age of 43, I was realizing that we were focused on everybody who was leaving the workforce, leaving the pipeline of those who wanted to become physician scientists. And every conference and books were written about it, and papers were written about it. And we talked about it all the time, but in the 22 years I was there, the needle hadn't moved. And I was convinced that we were looking at the wrong end of the problem. Much like the issue that we're having today in the workforce, everyone was focused on those people who are leaving and trying to get them to stay. And I was more interested in those who were staying, specifically those whose work was so incredible. And I kept wondering, what if we can make more of those people? Because I bet you if we got more of those high achievers, then their work would more than make up for anybody who's leaving. So at the age of 43, while working full-time and raising my family, I went back to school, got my doctorate, have been studying physician scientists and how to optimize physician scientists. And I noticed that they all have 4 elements of success. And when I finished my doctorate, I became an assistant dean for mentoring. I designed and launched a mentoring academy, did that for 2 years, became chief learning officer and assistant professor of education and anesthesiology. And my job is to make people successful. And I realized that the same 4 things that I saw in the physician scientist, I continued my research and saw that it's the same things that astronauts do, and Olympic champions and NBA champions and NFL Hall of Famers and Nobel Prize winners and all of these incredible people. So I wrote a book about it, The Success Factor. And now I go around and I teach people how to leverage their success using these 4 elements. And doing it within healthcare has its own unique challenges, especially with what healthcare has been going through. Now, before the pandemic, everyone was tapped out, burnt out, spent, running on this hamster wheel. And then the pandemic really threw everything into a tizzy, so much so that at least in New York, we had to graduate our medical students early because we needed all hands on deck. So for me, someone who's in charge of making people successful, that was not the time, right? The time was not to introduce something new. It was really just to keep pulses on people. So I need to find out where people are, what they're able to work with, and how to get them to the next level. And to me, that's a dream job and what I get to do every day.
Ruth, thank you so much. I have a ton of questions that I've got them written down here, a ton of questions about how it is that you work specifically to help the physicians identify the things that they need to do in order to move forward. But before we get to that, Gila, I'd love to hear from you a little bit about yourself and about your work at McKinsey across hospital systems and really across the world, because you get to see what different geographies are experiencing. So tell us a little bit about yourself, please.
Sure. So my name is Gila Tolub. I'm a consultant and a partner at McKinsey. I am actually part of our Tel Aviv office now. I moved to Israel 6 years ago after 12 years in the US, and originally I'm from France. So, you know, I think in my work, since I joined McKinsey about 10 years ago, I did work with, you know, hospitals, but also with pharmacy chains, life science companies. You know, I even did work with vaccines when it was considered niche and narrow, and then I stopped hearing that. But, you know, I think what's most exciting now in my career is that about a year ago, we built also a high-tech hub in Israel with really the goal to help healthcare startups and scale-ups really expand their reach. You know, our mission is a little bit to, you know, bring the best of the world to Israel and bring the best innovation from Israel to the world. And we think we can, you know, be helpful to that way through both our large, you know, usual, you know, the clients that you expect McKinsey to serve, but also it can be helpful to the innovators that are actually, you know, shaking things up and, you know, where innovation is coming from. And we're seeing amazing things in Israel. You know, in healthcare IT, in decision support, in remote monitoring. And so all of this has been really exciting to us.
I think that's great. I think, Gil, one of the things that your introduction really made me think about was that there seems to have been an evolution in what we're seeing in healthcare IT. If in the beginning there was a lot of, at least Israeli technologies we saw that were focused on physician support and physician decision support, or even tools and pharmaceuticals, today there seems to be a continuous evolution in what the innovation is, so that it's going into every element of the healthcare system, not just in the OR or not just in the ER, but really working with physicians in a 360 way to help them improve. And Ofir, I'd love to hear from you a little bit more about yourself and about Shamaym, which is one of those innovative tools that's made its way into the healthcare system.
Okay, hi everyone, and I actually want to relate a little bit to what Ruth said, because it's very similar. So back to my background, I started as a pilot in the Israeli Air Force and flight instructor. And when we started Shamaym, the goal was to bring some methodologies and concepts from aviation into the business world, including healthcare. And we started more on the operational excellence side. But today we're starting to focus also at the training side, since we saw a lot of need over there. And we always used to say that I think that the Israeli Air Force Flight Academy is one of the most impressive places to train professionals and was said high achievers. We always mention that, you know, they train pilots in about 250 flight hours, which is half of the world average time to become really high achievers. And we're trying to bring the same concepts now into healthcare. And we see a great need around competency-based education that is now starting all around the world, and it's super exciting and super interesting. So again, working with Fortune 500 companies on the enterprises side, and now starting to work in healthcare, mainly in the training, but also around safety and operational excellence.
That's great. Thank you, Ofir. So let's jump right into it. Ruth, you mentioned this during your intro, and we've got a chance to talk a little bit before we got on this webinar. And you said the pandemic changed everything. That people were burnt out before and couldn't have imagined where they'd be now. But this transition that physicians and really the entire staff at medical institutions have gone through has been transformative. So I'm really interested in hearing from you, how has learning been impacted? How is particularly both continuous learning that physicians were doing on the ground, if you will, as well as those medical students? You mentioned, we had this this sort of call to action where medical students in their final year were actually graduated early because there was such a need. How have those caught up? What are you seeing in the world of learning in the hospital where you're serving today?
I think everything has changed dramatically because as you said, everyone was burnt out to begin with, but now people just don't have the capacity or the cognitive load to deal with any of the formal trainings and workshops that we used to do, because really they're just tapped out. They just don't have the energy. They have not been able to recoup. At the beginning, some of them did not have vacation or a day off in weeks and weeks and weeks. And when they did, it was, I have to homeschool this child. I have to take care of this parent. I have to get the grocery shopping. I can't really leave my house. I'm worried my family's going to get sick. So we had to really just infuse it in different and very creative ways. And we realized that some people like to read things for enjoyment. People did not have the patience to read long articles or books like they used to. And I know I'm one of those people. I read 70 to 100 books a year. At the beginning of the pandemic, I just didn't have the patience. I couldn't focus, right? All of our concentration was so in the work that we're doing that doing things for pleasure just didn't happen. So we started by writing some of these shorter pieces, having these shorter workshops on topics they wanted, on how to solve needs that they were having in the present moment. A lot of them needed one-on-one coaching. They wanted it about, here's one thing I want to work on. They would ask, they would drive that, and they would bring it forward. The other thing that has happened is that all of a sudden we're talking about failure in ways that we haven't done before. And Ofir, I'm actually happy that you brought up the topic of the Israeli Air Force, because I didn't even know that was your background. But in all of the literature about failure and success, it's the Israeli Air Force that's actually brought up as a model. Because what they do, they have after action reviews, which are, and correct me if I'm wrong, this is what the literature is showing, which are different than how the rest of the world in any industry works. Usually what happens when something bad happens, we look to point fingers, right? But what we learned from the Israeli Air Force is that anyone can give feedback at any time to anyone, even people who are higher ranked than them. That creates a culture of safety. That creates a culture where we're all in this together. That creates a culture of, this is not a critique about what you've done in the past, but this is a way to improve it in the future. That's a very, very, very different mindset that we're usually not used to, especially not in healthcare. Because in healthcare, when you fail, somebody can die. But
so that's exactly it. How have you seen the culture shift to accept that? Because as you said, that's sort of a tough pill to swallow, if you will.
Yes, I'm not sure that we have accepted it yet, but I think as people have become more openly vulnerable and transparent about what they were going through, and that starts from the top down, that really gives other people the opportunity to do that. So, for example, when my father passed away in August 2020, the people who I work with knew that, and they knew that that's hard. It's hard to be able to go through the mourning process of losing a parent and work and focus and keep a smile on your face while you're doing it. And people gave me space as needed. And we worked through that, but then other people started doing that as well, sharing their triumphs, sharing their challenges, and people were there for each other in whatever way that they needed. Right. And I think that's very helpful. So there were definitely a lot of lessons, I feel, that we learned from the Israeli Air Force. I'm so glad you brought that up.
Ofir,
was I right? Was I right?
Ofir, I would love to actually hear not only your feedback on what Ruth just shared, but actually I know that you guys have brought some of these systems and had them operationalized in hospital settings. How have you seen physicians who are used to perhaps being sort of the end word or entrusting in not necessarily being in that sharing environment beforehand, how have you seen them adopted, and what are the results?
Yeah, definitely. First of all, that's how we started. Before we built technology, we worked with a lot of teams, including in hospitals, to learn, to see what are the challenges, to teach them how to create the same culture we've talked about. And it was really amazing. And it shows results almost 100% of the teams we work with. You see different culture, you see people that are more, as Ruth mentioned, vulnerable, much better safety. We actually have a partner at the Ha'emek hospital in Israel that published a research they did and improved so many different aspects in their safety, real measurable aspects in their safety, and it really is amazing to see. I think what we're trying to do now with the technology is to scale the impact, because you can't really go from a team to a team and go for, and work with all the hospitals in the world in such a way. The technology, and that's where innovation in healthcare maybe steps in, is how you can bring it maybe in a little bit lower scale of culture, but a much higher scale of people who use it and the impact that you do. And I think that starting through training and residency programs is a great place, because people are much more open to learn and to share and to speak about mistakes if needed when they are on training. And attendees are much more open to do those processes as well when they are coming as tutors and not as physicians who speaks about their mistakes. And the ability to combine between the mandatory administration's needs to the learning, to the feedback, and to tools that helps departments to build better doctors or to grow better doctors. Mm-hmm. I think that's kind of the need that we see right now.
Gila, we mentioned a few words here that I'm not sure are always top of mind when we think about systems. We talked about vulnerability, and we talked about openness, and we talked about cultural changes and learning. How have you met really those cultural frameworks in your work with so many different healthcare environments?
It's so interesting, this discussion. Yesterday, I was meeting the head of a innovation center at one of the hospitals here in Israel. And, we were chatting. It was really an intro meeting to get to understand what they're doing in terms of innovation, what new things they want to bring in. And very quickly, I started talking about a few of my experiences with hospital systems and change management, because actually, I think we spend so much time talking about the technical aspect of it, and not enough time talking about the human aspect of adopting those new technologies and, how it's going to change the day-to-day, a standard of care, and, just the way I practice, right? And it's very interesting because, it was a really open conversation. And I speak a lot about vulnerability in the way I do my work, because we know that when you are asking people to change their behavior, first of all, we don't change organizations. You're not going to go into an organization and change that's not a thing. You change the people in the organization. You change the way they behave, right? And I was telling her that I worked for a health system in the US that had more than 40 hospitals at the time. Now there's even more consolidation, it's much bigger. But already at the time, we were talking about 40 hospitals. And they had this big goal of changing, reducing turnaround time in the OR, and also starting on time in the morning, which seems like a simple goal, right? And, given all the work we do, we actually know what you need to do to start on time and what you need to do to, but because we're talking about human beings who are so entrenched in the way they work, we had a framework, we had an approach to doing things, but we started anew in every single one of the 40 hospitals because we needed to create a team of head nurse, anesthesiologist, technician, and they each spoke about what are the major pain points in their OR, which could be different than other OR. What would be the first one they want to solve? What's the technique they want to use to solve it? And because they had written their own lottery ticket, I don't know if you guys are familiar with the lottery ticket social experiment. It was better. All right, so lottery ticket social experiment, one of my favorites. You give two groups of people lottery tickets. The first group of people is a pre-printed lottery ticket. Second group of people, they write their own numbers. You give it to them, they own it for like 2 minutes. I don't remember exactly how many, but very little time. And you want to buy it back. Let's assume the lottery ticket is worth €1 or $1. How much does the first group sell it back to you? The one whose numbers were pre-printed? Just a guess.
Let's go with 1.
2, because just the fact that they have it in their hand makes it more valuable. Human behavior. Second group of people, they wrote their own number. They wrote their own lottery ticket. How much money do they want for it?
Ofir, Ruth, any guesses? I'm putting it at 5.
They want 8.
8?
They want 4x. They want 4x the other group, and 8x was the ticket was worth. Because they wrote down the numbers themselves. Kid was born. They wrote down the year their kid was born, maybe the date of their anniversary. They wrote down the things that they cared about, and they made it their own lottery ticket. By the way, wrong thing. If you want to win the lotto, much better to take the computer. It has a bigger range of numbers. It doesn't use only 12 months and 31 days. So the point is, when you want people to change, you need to have them write their own lottery ticket from the beginning. Mm-hmm. And so all of the new efforts we're doing to bring in new technology has to take this into account. We can't just push things on people. We need to engage folks. I can tell you that this conversation we had together, and I spoke about change management and the way we work in hospitals, it's like, wait, that's what we need to do, because I'm thinking about all the things we try to innovate around, all the things we try to bring into the hospital. Maybe we're just not engaging people early enough, right?
Mm-hmm. Ruth, I think that this is, I would love to understand. Yeah.
So I'll just say, maybe we're not engaging the right people, because one of the things we learned is that, you have to understand who are all the stakeholders. And we used to look a lot at the department manager.
Right.
And now when we're entering again with the training solution, we're trying to speak both with the residents and the attendees and the program managers and the hospitals managers, and to really understand what is the need for each one of them. And I think that it's also important for change management, because if you do it only with the program director, now you'll go to implement it, but the residents won't want to work with it. So you need to see.
So I see a lot of nodding heads, and Ofir, you set me up beautifully, because Ruth, what I wanted to ask you was, are you seeing requests or calls for support in changed learning and more support for their continuous training amongst the physicians? And how would you categorize, or how would you characterize the people who are actually sort of taking that initiative and looking for that support versus those that perhaps you have to work a little bit extra hard to get them involved?
Yeah, first I just want to say, and I put it in our chat, what Gila was talking about is adult learning 101, right? This is started by who we were talking about in the pre-conference, which was Malcolm Knowles, who's the granddaddy of adult learning. He said, if you want adults to learn, you have to make it relevant to them, what's important to them. If my job is to make widgets, not so important, but if it is to get a paycheck so that I can support my family, well, then that is my goal. That is my intrinsic motivation. So it's really going back to what intrinsically motivates people. And I think that is what's so key, is we need to find ways to tap into people's intrinsic motivation. So it's really quite simple, is that the people who actually come to me, where I don't need to seek them out, they've got that fire burning within them. I had an intern that's a first year resident approach me during his first week of orientation and say, I hear you publish a lot about professional development in Nature. I was really hoping that we could collaborate on a project. Could I schedule a time to talk? I didn't have to seek him out. And, you know, several months later, he has a first author paper in Nature, which is one of the most prestigious journals in science. And he was the one who took initiative. But for other people, it's either a little bit harder because they don't socially like to approach people, or it could be because culturally they don't do that. Or second of all, they may not have found their intrinsic motivation. And that's where it comes in for me being the 95% extrovert. I tell people I've been tested, definitely 95% extrovert. I go approach them. So I would go approach them in the hallway, in the coffee break room, in, you know, wherever they are. I meet them where they are and start to chat to them and chat with them and find out what are their pain points, what really excites them, why that excites them so much. And we start that conversation going, and that leads to other incredible things. And most of the people who I've collaborated with on the big writing projects, big research projects, they started out as hallway conversations, because that's when they're most relaxed.
And when you're figuring out who the right person is in the hallway that you want to go after, what would you say are sort of the characteristics of that person? Why is Dr. A more ripe or ready for this sort of activity or this sort of work than Dr. B?
Well, it's first of all, they have to want to do it, right?
This really gets back to what Gila said, right? They're writing their own ticket.
They're writing their own ticket. They have to want to do it. Some people are just need to get through the day because they have so many other things going. Those are not the people I'm going to add another thing onto their list. They're barely keeping it together as it is. But there are other people who have figured this out right now. They either have what we have something that we call in adult learning a margin of load. So a margin of load are all the things that you have to take care of, all of your responsibilities. And then what do you have to help you with those responsibilities? You have a nanny, you have a housekeeper, you can order takeout, right? All of those things that can help you. And different people have different opportunities to have more or less of that. Well, based on that, some people are able to move forward and do some more. Now, you can't tell me an intern during their first year when they're working God knows how many hours has a lot of time. No, they don't. They're exhausted all the time. My days were his nights. But some of them figure out a way to make it work because they're so hungry for it. And you can tell with those people. And other people, it's there, you just have to bring it out of them.
That's great. Gila, I'd love to transition a little bit over here, because one of the things that seems like a clear and necessary input is data that is properly accessed, properly sort of aggregated and analyzed. And I wonder how you have interacted or what you've seen from the healthcare systems about, are they keeping their data differently? Are they collecting it differently? Are folks being able to use it for their continuous learning, right? When we're talking about this 360 loop and feedback, and both in the moment as well as long term, how are you seeing the healthcare systems take care of their data, access it, and actually utilize it in learning and in improvements that they're making?
Yeah, and it's interesting you're asking that. First of all, earlier when you said about the fact that, you know, solutions used to be only point, you know, healthcare IT in the back office or then specific things. Now I think we're even seeing systems that are connecting hospitals together, right? There's a startup in Israel, MD Clone, that's helping, you know, hospitals within Israel and outside of Israel share data, create data that's completely HIPAA compliant, right? So that they can work together on research. Now, talking about like learning, I think that there's a really big range. You have some hospitals that are doing great and using a lot of data to kind of help their folks. And continuous learning is really about having immediate feedback, but also the opportunity to step back and look at the results. I'm sure Ruth has seen a lot of that in her work, right? But so, for example, like if you think about the work that was done about 10 years ago to get hospital-acquired infection down and falls down, right? It was a mix of, providing the tools to every day see the progress, providing the tools to actually track people habits in terms of like washing their hands, cleaning, etc. But seeing, results right away and seeing what works. And it's about testing and learning. And again, it's about, involving people in designing new solutions, right? Where should we put the alcohol gel, right? Where should we put, realizing that if you put it there, there's actually 3 steps out, away from the bed, from the patient to get it versus, straight. So there's even a little bit of operation. So a lot of things come in, to make sure when you're doing behavioral change. And I think, what we've seen is, the motivation is super important. For example, on finding the motivation, telling the story, right? So for example, when we did all this work on hospital-acquired infection, it was very easy to make people understand why, right? Nobody wants that to happen. Today, when you're making other changes, it's harder, right? Because people have different motivations, like Ruth was talking about, right? And you have to make sure that you don't leave people behind by focusing too much on one message. But also you need to give them the tools to succeed, right? So the alcohol gel is one, the making sure that there are incentives in place, either a carrot or a stick, depending on where you are. That there is also training super important, capability building, understanding what causes hospital-acquired infection, right? And also role modeling. And like you said, it's role modeling. It's super interesting because it's not only about the department head, it's also about the people who speak the loudest at the coffee machine, right? Ofir was saying you need to talk to the interns and the residents and everyone, but really you need to understand who are the influencers in this place, right? It's probably not always the people at the top. There are folks whose voice are heard much more than others.
Thank you for that, Gila. That's really helpful thinking. I know, Ofir, you've brought this sort of sense as part of Shamaym. You're bringing sort of the sense of data and analytics, the machine learning that sort of analyzes that, as well as improving the training processes. And you've mentioned the competency-based medical education approach. How are you thinking about these differences and these changes happening in both the best practices for medical education and then in the sort of changing environment of medical institutions? How have you guys actually implemented some of this work, and what's your thesis? How is it that you're addressing these changes?
Yeah, so first of all, I have to say that, we've been in a couple of large conferences, medical education conferences in the last month, and spoke really to a lot of people. And it seems like, although it's there for a few years, it's still new. Most departments look like they're still looking to really understand how to manage the competency-based, how to measure it, how to combine it in the day-to-day. So I think it's kind of still like a learning process. So that's what we hear. The way we approach it is first of all, because our platform is so customizable, we're trying to work with them and to build with them. It's pretty similar to what mentioned here before. Let them write what they want. So I think that's our main approach right now, to provide them with a very simple and customizable platform that will help them take all the thinkings that they have right now and try to actually build something that will work for them. And one of the advantages is that then we can scale it between different departments and show some departments what other departments have done. So that's kind of how we look at it right now.
Ruth, are you seeing that hospitals are sharing that sort of information about best practices in learning? Is that something that you're seeing physicians talk about happening at different hospitals that they want to bring to their own, or is this sort of bandwidth challenge such that it makes it hard to share?
I think in academia, where we need to study things, we need to look at things, we need to review things, we need, right? So things are a little slow to materialize. But what happens when any of us go to a conference, we see something new, we get so excited, we want to bring it back to our institution. But that excitement fails when we have to get back to our day jobs and we get so busy doing it that we don't even have time to connect with the people who can actually implement it. Because what we know with adult learning, some people are great with the ideas, other people are great with execution. And those people are not always together. And I think if we start to get those people together, we can actually move things a lot faster. Because we know that on the adult learning wheel, there's different parts. There's people who are looking for all the problems. There are people who are identifying all the solutions. There are people who are able to visualize what it would actually look like. And then there are people who get it done and execute it. We need to create teams with all of these people. People want improvements. People want to see things better so that their lives can be better, right? It goes back to how can it be better for me? But we're still missing some steps in order to make that happen. We'll get there.
Yeah. Gila, I wonder if there's any learnings here from some of the other innovation or technology implementations that have already taken place in hospitals, right? So there have been, obviously, over the course of the centuries and maybe in a more accelerated fashion, even in the last decade, where we've seen even startups and new technologies find their way into the hospital setting more quickly, or perhaps in a different way than we'd imagine. What are do you think are the right stations or the pathway for technologies to get into the healthcare system and the hospital systems in such a way that they do get used, that they do get implemented, that they do get to the right people so that they can make that life-changing impact that they're designed to do?
Yeah, no, I think it's a great question. First of all, I think healthcare IT, like the whole back office, has been a great example, right? It's been pretty successful from the beginning. I think one of the main reasons was that nobody likes back office and doing a lot of this thing, right? So people are like, yeah, you're taking work away from me, great. But that's the point, right? We need to be solving the core problems of our physicians, right? And we need to explain to them how the new technology we're bringing is helping solve those problems. And by the way, when I say physicians, I apologize because I actually mean everyone, nurses, staff, right? I actually think we're not innovating for nurses enough. I think that as long as the innovators really are solving a key pain points for the care delivery and are able to explain that in the why, in the story of the why, but then also making it easy to learn so that you're not changing too much the standard of care or the way you do things. I mean, I don't know if you guys have heard the statistics, right? But people practice the way they learned in school. It's very hard to change, like Ruth was saying. So when there's a new recommendation in the Journal of New England for a new way to do something, it takes about 13 years for complete implementation of that new recommendation, right? So we need to make that much easier. For example, technology is making that easier by making recommendations in the EMR, right? Telling this is the diagnostic, or this is the data is already being collected. Hey, this patient is at risk for preeclampsia. Be careful, right? Or hey, this patient is. So there are things that technology is really helping with, and physicians embrace that really well, right? But I think, it starts with solving the biggest problem. And I think healthcare IT, was doing this with, taking away. Now there's a startup here in Israel, Ilios, who's helping, mental health practitioners with note-taking, automatic, language recognition, and helping them also write their notes, etc. So all these things that will help physicians will be much more easily, adopted.
That's great. I think one of the things that that resonates with me is that you have to make it easy for people to actually do. Ruth, also you've talked about this, that at the end of the day, you have to be able to tell somebody not what and why they're doing it. Those are clearly important, but how they're actually going to do it. Ofir, when you guys get down to it, what is it that you're asking in the feedback loop, or what is it that the physicians and the medical staff is asking that's helping make those decisions smarter, their improvements more sustainable?
First of all, I think it should mainly be as simple and easy as possible, because if you want to get the best data, you can ask tons of questions. So you have to understand you won't get all the data that you want. So you really have to pinpoint what is the most important data that will help all the stakeholders. And I think that's one of the biggest challenge. When do you want them to work with the technology? What do you want them to enter to the technology? What kind of data to take out of it? So that's one. Second, we usually try to get them to just stay with the same process they are already doing. Again, it's going back to the change management. If you change the way they do it and you change, how the structure is, it's two changes together. So take them from the manual work or from the old technology to the new technology, focus only on that. Only when they're on and it's implemented, then try to think how you can help them make it better.
That was great, Ofir. Thank you so much for that. Ruth, Gila, Ofir, this time has flown by. So thank you guys all for sharing of your experience and of your perspective. What I'm taking away from this conversation is, first and foremost, a genuine and authentic desire amongst so many players within our healthcare systems to continuously improve and to continue to make our lives healthier and safer, but also recognition that we're talking about people who are really worked to the max, need to continue to get the support that they need in order to continue learning, to continue implementing, and that if we make it, on the one hand, possible to be vulnerable and open, and on the other hand, make it easy to learn and change and adjust, we're just going to continue to see these systems that have truly been life-changing continue to grow and become even more impactful as we move forward. So thank you, Ruth, Gila, and Ofir for taking the time today for this conversation. Professor Ginzo has actually let us know he had to be called away for a very, very critical call, but he will be back another time. So do all stay tuned for the next time we will have an opportunity to speak with him as well. Thank you all. It's been a pleasure to be here, and have a good rest of your day.
Thank you.
Thanks all. Thank you.